الله الرحمن الرحيم. طلبة الصف الرابع مادة امراض الجهاز التنفسي. محاضرتنا لهذا اليوم هي diseases of the pleura. As we know, the pleural cavity, also known as the pleural space, where the lungs occupy this space, is a thin fluid filled space between the two pulmonary pleura known as visceral and parietal pleura of each lung. As we know, we have two pleural layers, one called parietal, which is the outer one, and one called visceral, which is the inner one that cover both lungs and separate. So in a normal 70 kg human, this pleural space contains few milliliters of serous fluid, and this is always present within the intrapleural space, and this is important for movement between the visceral and parietal. So this fluid, serous fluid, behave as lubricant to improve or to facilitate the movement between visceral and parietal pleura, especially during breathing. So what are these pictures show the pleural space or pleural cavity. This is the purple in color, this is one, and this is the red one is the peritoneal cavity. This is the bladder, and this is the CSF space. So what are the diseases of the pleura? The first one which is called pleurisy. Very important point have to have known. A pleurisy is not a diagnosis, but a term used to describe a pleuritic pain resulting from any one of a number of diseases or processes involving the pleura, like infection, infarction, and it may also occur in malignant diseases that affect the pleura, and the patient might present to you with a pleurisy. So the pleurisy is a symptom rather than a diagnosis, rather than a disease. So what about clinical feature of patient present to you, or what are the clinical features of pleurisy? Pleurisy described as a sharp pain that's aggravated by deep breathing or coughing, and this is the characteristics of this pain. It is sharp and aggravated by deep breathing and aggravated by coughing. On examination, sometimes you hear a rub. Rub means movement is restricted and a pleural rub may be present. So the pleural rubs is present when the parietal and when parietal pleura move or on the visceral pleura. So this is on the examination, and you find a rib restriction in this area when they involve by pleurisy. Sometimes this is the only audible in deep inspiration or near the pericardium, and this is called a pleuropericardial rub. In addition to the pleural rub itself, we have what is called pleuropericardial rub, and this is only audible in deep inspiration or near the pericardium. The other clinical features depend on the underlying cause. I mean clinical features of pneumonia, for example, infection, clinical features of pulmonary embolism, infarction, clinical features of malignant disease involving the pleura. So, when you examine the patient with a pleurisy and there is loss of pleural rub, what does that mean? So, that means that the loss of the pleural rub and diminution in the chest pain may indicate either recovery or the development of pleural effusion. Okay, this is very clear that loss of pleural rub and diminution of the pain due to the pleurisy may indicate either recovery or the development of a pleural effusion. What are the investigations done to a patient present to you with the pleurisy? The most common investigation done, it is chest X-ray. But if normal, this does not exclude a pulmonary cause of pleurisy. A preceding history of cough, pleural submutum, and pyrexia is a presumptive evidence of pulmonary infection, which may not have been severe enough to produce a radiographic abnormality, or which may have resolved before the chest X-ray was taken. So when you do a chest X-ray to the patient with suspicion of pneumonia or chest infection and present to you with the pleurisy, and you find normal chest X-ray, this is not to exclude the disease. Why? Because the disease findings or disease abnormality or disease pathology in the lung is not enough to produce a radiological findings, or may be resolved before the chest X-ray was taken. How to manage patients present to you with pleurisy? First of all, have to treat the primary cause of the pleurisy, whether infection, function, malignancy, etc. And the symptomatic treatment of the pleural pain by simple analgesia and painkiller. We have another topics after finishing the discussion of pleurisy. It is called pleural effusion. So what is the definition of pleural effusion and what are the types of pleural effusion? A pleural effusion is the accumulation of serous fluid within the pleural space. The accumulation of serous fluid within the pleural space. So, another term we have what is called empyema. So what is the empyema? Empyema is the accumulation of red pus within the pleural space. What about hemothorax? Hemothorax, the accumulation of blood in the hemothorax. What about the chylothorax? The accumulation of chyle in the pleural space. So we have pleural effusion, accumulation of the serous fluid. We have empyema, accumulation of the pus. We have hemothorax, accumulation of the blood, and we have chylothorax, which is the accumulation of the chyle. So what is the mechanism of accumulation of the pleural fluid? Pleural fluids accumulate as a result of either increased hydrostatic pressure or decreased osmotic pressure, and this is called transudative effusion. And we will discuss what means by transudative, or how to diagnose the transudative and oxidative pleural effusion. And this transudative effusion is seen in cardiac, liver, or renal failure, or from increased microvascular pressure to disease of the pleura itself, or injury in the adjacent lung, and this is called oxidative effusion. The cause of the majority of pleural effusion can be identified through a thorough history, a thorough examinations, and relevant investigation according to the underlying cause. So, what are the causes, or common causes and uncommon causes of pleural effusion? Okay, as we said, pleural effusion is the accumulation of the serous fluid in the pleural space. So, what are the causes of pleural effusion? We have common causes and we have uncommon causes. The common causes include parapneumonic effusion. I means effusion due to the pneumonia. Second, tuberculosis is one of the common causes, especially in our society. Pulmonary infarction, malignant diseases like bronchogenic carcinoma or secondaries. Cardiac failure, heart failure. Subdiaphragmatic disorder, subphrenic abscess, pancreatitis, etc. Uncommon causes: hypoproteinemia, nephrotic syndromes, liver failure, malnutrition, connective tissue diseases, example systemic lupus erythematosus, rheumatoid arthritis, acute rheumatic fever, post-myocardial infarction syndrome, which is called Dressler syndrome, Meigs syndrome, emphysema, uremia, asbestos related benign pleural effusion. This table shows the common cause of pleural effusion and characteristics of each one, starting with appearance of the fluid, type of the fluid, predominant cells in fluid, other diagnostic health or features. The most common cause as an infection start with tuberculosis, the appearance of the fluid, serous, usually amber color, and the type of the fluid, exudate, and the predominant cells lymphocyte, and about 20% positive from positive tuberculosis. Isolation of mycobacteria tuberculosis from pleura is about 20%, can be isolated, and positive pleural biopsy about 80%. Other cause, malignant disease, type of fluid oxidative, and appearance of the fluid, serous and often blood stains, and positive pleural biopsy in about 40% of the cases. Other causes, cardiac failure and the type of the fluid, transitive, pulmonary function, oxidative, rheumatoid arthritis, oxidative, and the predominant cells lymphocyte, and rheumatoid factor and anti-CCP antibodies positive. Cholesterol in chronic fusion. Cholesterol, we find cholesterol in the pleural fusion and the chronic fusion due to the rheumatoid arthritis. Systemic lupus erythematosus, SLE, oxidative, and predominant cell lymphocyte, and other investigation, anti-double citrate antibody, anti-nuclear positive, help to diagnose of the SLE. Acute pancreatitis, oxidative, obstruction of the chyli, the appearance milky, and the predominant cells, non-predominant cell, and the appearance is chyli. And the help of the other investigation to help you who are high concentration of chylomicrons in the pleural fusion. Investigations for a patient with pleural fusion. First, imaging, the classical appearance of pleural fusion on the erect PA chest X-ray film is of a curved shadow at the lung base, blunting of the costophrenic angle, and ascending toward the axilla. So the first imaging investigation is the chest X-ray, which is important to diagnose pleural fusion, and the appearance will be a curved shadow at the lung base, blunting the costophrenic angles, and ascending toward the axilla. Fluid appears to track up the lateral chest wall. And how much pleural fusion to be appeared on the chest X-ray? Around 200 of the fluid is required to be detected on a PA chest X-ray. But smaller fusion can be identified by ultrasound or CT scan, and even below 50 cc. So anybody ask you how much amount of pleural fusion to be detected by PA chest X-ray, have to have answer him or answer them. The amount is about 200 ml. Previous scans or adhesions in the pleural space can cause localized fusion. Pleural fluid localized below the lower lobe called subpulmonary fusion simulate an elevated diaphragm. Sometimes we found an elevation of diaphragm, but is not real elevation, which is due to the subpulmonic fusion. Fluid sometimes localized within an oblique fissure and may produce a rounded mass or opacity, and this is sometimes misleading as a tumor. This is the chest X-ray, so the curved shadow and obliteration of the lower lobe of the left lung and curved shadow. This is characteristics of X-ray finding of patient with fusion. Sometimes only blunting of the costophrenic angle, as you show on the left side, it's a blunting of costophrenic angle of this patient with pleural fusion. Other investigation, ultrasound is more accurate than plain chest radiography for detecting the volume of pleural fluid and frequently provides additional helpful information. The techniques may also distinguish pleural fluid from a pleural technique. So ultrasound helps us to distinguish pleural fluid from the pleural space. Other investigation is computed tomography, CT scan, and displays pleural abnormalities more readily than either radiograph or ultrasound, and may distinguish benign from malignant pleural fusion. Other investigation is a pleural aspiration and biopsy, and this is sampling is necessary to establish the diagnosis, and simple aspiration provide information on the color, textures, appearance, which may immediately suggest an impairment or chylomicron. So from the appearance, from the color, from the texture, can be lead to the underlying diagnosis or suspected diagnosis. Sometimes presence of the blood, which is consistent of pulmonary function or malignancy, and maybe traumatic tap. Sometimes traumatic tap lead to the appearance of blood in the pleural aspiration. So the appearance, the color, the textures are very important. Biochemical analysis show differentiation of the transudates from the exudate. Ground stains may indicate parapneumonic fusion. We have what is called light criteria for distinguishing pleural transudate from exudate. Pleural fluid is an exudate if one or more of the following criteria are met. First, a pleural fluid protein to the serum protein ratio more than 0.5. A pleural fluid LDH to the serum LDH ratio more than 0.6. A pleural fluid LDH more than 2/3 of the upper limit of the normal serum LDH. These goes with oxidative pleural fusion. So I repeat, when the pleural fluid protein ratio to the serum protein more than 0.5, when the pleural fluid LDH to the serum LDH ratio more than 0.6, when the pleural fluid LDH more than 2/3 of the upper limit of the normal serum LDH, these indicate this fluid and oxidative when one or more of the following criteria are met. Other investigations, cytological examination to provide us types of cells, pH suggestion, very important. pH detection suggests infection, but may be also seen in chronic rheumatoid arthritis disease, rupture esophagus, or advanced malignancy. Combining pleural aspiration with biopsy increase the diagnostic yields, especially in tuberculosis. The best results are obtained from video assist thoracoscope. How to manage patient with pleurisy? When there is a breathlessness due to the large number of fusion, so we have what is called therapeutic aspiration, which may be required to palliate breathlessness, but removing, very important, have to concentrate, but removing of more than 1.5 liter in one episode in one session is inadvisable, as there is a small risk of re-expansion pulmonary edema. And infusion should never be drained to dryness before establishing the diagnosis. Why? Because a further biopsy may be precluded until further fluid accumulate, because we might need further biopsy. So never drain until dryness. Treatment, other last aspect of management with treatment on the underlying cause, for example, treatment of the heart failure, treatment of pneumonia, pulmonary embolism, and other causes of pulmonary or other causes of pleural effusion. Thank you.